Hi everyone, welcome to our first video lecture of the term. So this is going to be the first lecture for what I'm going to call part 1 of all the lectures. Anything posted under part 1 on eClass will be for midterm 1. So that's how you'll be able to recognize what stuff will be covered on the midterm or not. So today we're going to go over what is pharmacology, what is pharmacokinetics. So for many of you, this may be a review. For others, this might be some new stuff, but this is the building blocks of what we're going to be talking about this whole term. So if you have questions on this part, please make sure you ask any questions because this is all really fundamental stuff that you'll need throughout the course. So again, today we're talking about pharmacology and pharmacokinetics. So the first thing you're going to need to know is what is neuropsychopharmacology. So neuropsychopharmacology, we can break that down. Neuro is brain, psycho, psychology, and then pharmacology. So breaking that down, we can see that it's the study of the actions of drugs on the central nervous system and their subsequent effects on human behavior. So this is, again, the focus of the entire class. Are these neuropsychopharmacologies. Now, when we're talking about drugs, we often will talk about drug actions as well as drug effects. So you're going to need to know the difference between these two terms. So the first one is drug actions. So this is a very specific term for the specific molecular changes that results from the drug binding to a target site on a cell. So a drug binding to a receptor, the specific molecular changes that occur because of this binding, it's called a drug action. Now, drug effects is a bit more general. So drug effects refers to the widespread alterations in physiological or psychological results from drug actions. So we have a drug action and it will lead to drug effects. Okay? Now, traditional drug development is oriented towards identifying new drugs to have a desirable drug effect. So when we're designing drugs, the aim is to get a specific effect, and we do this by studying different actions. Okay? So for instance, morphine was developed to treat or to have the drug effect of nulling pain, whereas the drug action is that it binds to an opioid receptor in the brain, okay? So in order to make an effect or the changes you see or can measure, then that results from some sort of drug action. Now we'll mostly be talking about drug effects for the first part of this course, but we will also talk about the actions as well. So make sure you're familiar with different, like how cells communicate, how neurotransmitters bind to other cells. Now, when talking about drug effects, we can break that down even further to be more specific. So when we talk about a therapeutic effect of a drug, we're talking about the desired physiological or behavioral changes. So an antipsychotic drug, then the therapeutic effect would be the effect on those behavioral symptoms that come with some psychoses. But then you will also have side effects of every drug. So every drug has side effects, and side effects just means any other drug effect. So there's really two main categories of drug effects. There's your therapeutic effects, or the effect that you wanted, and then the side effects, so everything else you've got. Now within these side effects, there will be adverse effects. So these adverse effects are negative side effects. Okay, so these are undesirable or harmful drug effects. Now, many drugs usually will have multiple different uses, and so depending on how you're using the drug, it will dictate what your therapeutic effect is. Okay? Now, we're going to see an example here using Benadryl, okay? Now, before we get into this example of therapeutic effects and side effects, I first want to go over some terminology that you might hear me say throughout the course. And this is when we're talking about a drug. So, all drugs will have kind of three different names. The first one is the abbreviated chemical name. So that would be this diphenylhydramine. So that's kind of an abbreviated chemical name. And we get that name from the IUPAC name, or the full chemical name. And so you can kind of see how the name we have here, which is naming the chemical structure of the drug, can get condensed, right, into the abbreviated chemical name. So we've got that diphenyl here, or diphen, and then we've got dimethylphenamine over here. So kind of combining all of that, that's how we get this abbreviated chemical name. Now the third name is what's called a trade name, or this might be the brand name. So Benadryl is the trade name for this drug. So it's like the brand that you associate with it, okay? So when you get an off-brand Benadryl, the drug you're getting will have a different trade name, but it will have the same abbreviated chemical name, okay? Now, let's get back into talking about therapeutic effects versus side effects. So we're going to use this example of Benadryl. Now, Benadryl is usually used as an antihistamine and decongestant. So that means the therapeutic effects of using Benadryl as a decongestant would be the effect of drying the mucous membranes. Okay, that's the effect we wanted as a decongestant, as an antihistamine. The side effects of Benadryl is that one of them is that it causes drowsiness. So because it causes drowsiness and that's not the use we wanted, then we call it a side effect. However, some people do take Benadryl as a mild sedative for insomnia. So when people can't sleep, sometimes they'll take Benadryl. And if you're taking Benadryl for insomnia, then your desired effect or your therapeutic effect would include drowsiness. And that means that your side effect is going to change as well. So now your side effect includes the drying of the mucous membrane. So you can see how the therapeutic effect changes based on what you're using the drug for. And then the side effects are, again, just everything else. Now, when we're talking about drug effects, we'll also talk about the specificity of these drug effects. So a specific effect occurs as a result of biochemical interactions between a drug and a drug receptor. In other words, the drug is going where you want and acting exactly where you want it. That's your specific effects. Your non-specific effects is, again, kind of everything else. So it occurs as a result of an interaction between the receptor, beyond the receptors. So this means that it could be an effect in the lipid membranes, it could be in the fluid compartments. It may also occur as a result of some unique characteristics of an individual or an individual's state. So in other words, these non-specific drug effects are often affected by an individual's mind, mood, and expectations of the drug efficacy. Now, one of these non-specific effects, which is obviously, like I just said, connected to the expectations of the drug efficacy, is very major, and you've probably heard of it. It's called the placebo effect. So the placebo effect is a measurable therapeutic effect of a treatment without specific activity for the respective condition. Now, the placebo effect is very much affected by expectancy and conditioning. So we see the placebo effect a lot of times in drug research, especially in neuropsychopharmacology. Placebos are used a lot of times to see how effective actual drugs are at treating something. So in all of these drug trials, then participants are either given the drug or a placebo, and then what they're measuring is the difference or how much greater the effect of the drug was than the placebo. So if the placebo and the drug have the same effect on behavior, then we'll say that the drug was not effective and that any changes in behavior were due to expectancy or the placebo effect rather than the actual drug. So many antidepressants have an efficacy of about 50 to 70% in major depression, and we figured that out because the placebo, just giving a placebo, is effective in 20 to 30% of cases, whereas the antidepressant is 50 to 70%. So that's significantly more of an effect in the antidepressant group than in the placebo group. Therefore, the antidepressant is said to work. So during the development of fluoxetine, also known as Prozac, then it actually had to endure 5 clinical trials just to show that the antidepressant group had a greater response than the placebo group. So a lot of these drugs struggle to get past this phase because the placebo effect can have such a great effect on people's behavior. Now, when talking about why the placebo effect works, then we actually have different explanations depending on who you're talking to. So psychiatry versus psychology, they kind of differ in how they explain what happened. So psychiatrists will actually say that the placebo effect is the effect attributed to regular visits with a psychiatrist, whereas a psychologist argues that the placebo effect demonstrates the effectiveness of psychological intervention. In other words, you don't need to visit a psychiatrist in order for the placebo effect to work, just that you need to have some kind of psychological intervention, which could even just be tricking yourself into taking a sugar pill. So personally, I just think that means that the psychiatrists are a little full of themselves. But, that's fine. I have an example here of a classic experiment. Now, this is using placebos, not for a neuropsychological thing, but just for ulcers in the stomach. And even then, so for problems that are not, what we might describe as a psychological problem, but as a actual biological physical problem in the stomach, having an ulcer, even just giving a placebo to these patients was still very effective. So group A was given a placebo, and the doctor told them that it would work. So they didn't know it was a placebo, and it actually worked on 70% of the patients to relieve their ulcer symptoms, where group B was given the placebo by a nurse and just told, oh, this is an experiment, we don't know if it'll work. And even then, 25% of patients still saw some relief. So you can really see the power of a placebo effect on people for injuries all around the body. So in drug development, these pharmaceutical researchers have actually recently argued that placebos should be discontinued for antidepressants because we have so many antidepressants already in the field that now, in order to test new antidepressants, new drugs, then we should actually replace a placebo group by giving the control group a drug that's already in the field, and then seeing if the new drug can actually make it better. So demonstrating an efficacy equivalent or greater than the existing approved antidepressant.